Good afternoon. My name is Susie Rapp, and I am our moderator today, and welcome from UW Telepain. Our lecture today is being presented by Dr. Kari Stevens, who's going to talk to us about PTSD.
Thank you, Susie. I understand there may be some of you who may have heard me lecture about this about 6 months ago. So for those, if it's boring repeat for you, I apologize. But I hear there's also lots of new folks on that hopefully will find this pretty useful. So there's a huge overlap in post-traumatic stress disorder and pain, which is what I aim to talk about today. And hopefully, in addition to giving you some information about how that overlap functions, to actually give you some practical information about things you can do to help patients that have got both issues going on. So what is a traumatic event? This is getting redefined somewhat in the new DSM-5, but we always want to start there. You can't have PTSD without a traumatic event. So you want to make sure that there is some kind of index trauma that's either an experienced, a witnessed, a learned about, or repeated exposure of some kind to either an actual or a threatened death, some kind of serious injury, or sexual violence. And so people can actually just witness this happening as well. It doesn't have to be happening to them anymore. And there's some loosening of this definition of trauma now that we understand can also relate to PTSD. So remember, when you're diagnosing PTSD, that these symptoms need to be persisting for at least a month, and the patient has to have some kind of significant distress or impairment going on. And we now have 5 different criteria that go along with the PTSD diagnosis. The first being the re-experiencing set of symptoms, which is really where the trauma itself, or the traumas, in many cases it's more than one trauma, are coming back to the person in some kind of uninvited way. These can be memories, dreams, flashbacks, even just the physiological re-experiencing of what happened during the trauma based on reminders, or some severe kind of psychological distress at the reminders. So there needs to be at least one of these kinds of symptoms happening. They need to have at least one kind of avoidance of these kinds of intrusions. So some kind of avoidance of memories, thoughts, or feelings, or some kind of avoidance of external reminders that are things like going places that remind them of those things, doing activities, engaging in smells, sexual activities for those with sexual trauma, conversations, etc. The hyperarousal piece is requiring now 2 different symptoms, including some irritability and anger that is much worse than before the trauma itself, some kind of reckless or self-destructive behavior afterwards, the hypervigilance and the startle we're very familiar with, difficulties concentrating and difficulties with sleep. Often that can overlap in nightmares occurring related to trauma. And then in terms of cognitions and mood, they need 2 of these symptoms. And this is where you're seeing a change in the DSM-5 or across these 3 bottom clusters of hyperarousal, cognitions and mood, and avoidance, where we've reorganized what those symptoms need to be in the new way that we look at PTSD. So I think the cognitions and the mood issues are pretty self-explanatory as well. It can be memory loss about the trauma that's not explained by some kind of head trauma, but the person simply doesn't remember important aspects of what happened. Intense negative self-beliefs are a new criteria that have been added, and this is really pervasive in pain in particular, where people think very poorly of themselves. The same that self-blaming persistence you'll see as well is also one of these new categories of symptoms we've put in there. So people that are constantly saying, it's my fault that these things happened, it's my fault right now that my life is terrible, I'm to blame for why I don't get up and move around. You'll see this lens of self-blame with people with PTSD that they can wear quite easily. Lots of negative emotions, anhedonia, these are things that overlap with depression. Detachment from other people. They can actually be around lots of people and may even have people in their lives, but they just feel disconnected from them is a common symptom. And then lacking any kind of positive emotion. So I'd just like to start there to refresh everyone's memory and let you know what the symptoms of PTSD are. And then talk a little bit about whether or not trauma always causes PTSD. I think sometimes there is a misconception we can get to, especially when we're treating a lot of patients with pain, that if they've got trauma, they must have PTSD. So I want to just make sure that we don't make that mistake and remember that actually most people do not get PTSD as a result of trauma. It's actually a very rare occurrence. And if you look at the NCSR data from a national sample, population-based sample, you'll see that somewhere between 70 and 90%, depending on how you define trauma, will report that they've had at least one traumatic experience. So what I tell my patients is that, it's common that the vast majority of people have experienced trauma in some way, and it's also really common as a part of that trauma experience to have post-traumatic stress immediately following that event. What happens with PTSD is we get stuck in that experience, and that post-traumatic stress doesn't dissipate like it does for most people as a normal response. And so we call it kind of a stuck point of getting stuck in the healing process from trauma that has occurred to us. So in terms of prevalence rates, about 7% or so of adults report in the U.S. having PTSD. Women are over 2 times more common, more likely to have PTSD than men. And there's a newer study that just came out recently that evaluated the NCSR data for rural versus urban differences, which I thought was nice for this ECHO group because I know many of you are out in rural settings as well as urban settings. And there actually isn't any difference, according to that study, in terms of prevalence rates of PTSD. So we're dealing with PTSD everywhere is the bottom line. So it's just confirming for us that we need to know how to deal with this in all settings. Among vets, the lifetime prevalence, there's differences based on war experiences here. So you can see with the Vietnam War, it was around 30% or so, and the Gulf War at 10%, and the current wars, the prevalence rates range drastically kind of depending on the sampling, so we don't have our full handle on looking at that group as a whole, but we know those rates are pretty darn high. A lot of that is tied to the fact that in the current wars, a lot of our soldiers are getting exposed to much higher doses of trauma than in the previous wars, both in terms of days of service, combat service, and incidences. So we also know that about somewhere between 35 and 50% of patients who have PTSD report some kind of chronic pain issue. So here's where the overlap starts, and it's not just about prevalence overlapping, but the mechanisms as well. We're starting to understand more and more overlap between these two issues. So you can see, so some of the studies are showing us that the rates for PTSD and chronic pain together are potentially higher in ethnic minorities. And then the way you can look at this in this bottom left-hand corner here is you can look at a PTSD cohort and ask how many of them have chronic pain, and studies will kind of range between 20 and 80% depending on the sample. Or you can look at a pain cohort and say folks with chronic pain, how many of them have PTSD, and that's anywhere from 7 to 50%. There's some nice reviews kind of looking at these prevalence data. It ranges because it depends on what you call chronic pain, and it depends on what you call, or which sample I should say you use to look at PTSD. But the bottom line is it's a heck of a lot higher than 7 or 8%, which is the population rate. So it's definitely higher. The higher the pain issue, or I should say, let me put it this way, people who have PTSD generally report more pain. They generally report more affective distress and more disability. That's a pretty robust finding that you'll see across many studies, which is, of course, common sense to us. You got PTSD and pain, you're worse off than if you don't have PTSD. There is some evidence growing around some neurobiological overlaps that folks are trying to move towards treatment. Experimentally, thoughts around whether or not progesterone or intense exercise might influence different neurochemistry pieces that can potentially help both of these issues, but we're very much in the early stages of this stuff. We don't really know what's going to pan out in that realm, but there is some neat work going on there, both looking at animal models and humans. We do know that the negative beliefs about a person's own self are mediating pain interference, which I'm sure you hear about in this ECHO group quite a bit. That we're not necessarily tracking pain levels so much as pain interference when folks have chronic pain that can't be cured and made better. So that'll tie in later when I talk to you a little bit about how we treat these things. So I also want to point out that PTSD and chronic pain, while they come together and there's a huge overlap in comorbidity, they also get better together. So that's the good news. So if we treat PTSD well, we usually can make some improvement in pain, and if we treat pain well, it usually can improve PTSD. There's an integrated treatment model that's been tested within a vet population that has proven this out, and it addressed avoidance for both pain and PTSD together, kind of under the premise of what we do a lot of anxiety treatment around, which is what we call exposure treatment, or having people learn in their brain how to stop avoiding things that they're fearing when they're not actually dangerous. We also know that PTSD, and again, a lot of this stuff is being done in vet populations these days. That's where a lot of the funding and a lot of where we see the major issues coming back with our soldiers hitting. But PTSD influences pain symptoms in the vet population. It's pretty clear, and there's a more recent study out of the UK where a multidisciplinary pain treatment program was found to be no less effective for those with PTSD than those without. So that's actually good news, because I think some people are worried because you see those higher symptoms with PTSD in pain and in disability, et cetera, that multidisciplinary pain treatment might be less effective for them, and this is a positive study in that arena, although I can't generalize beyond that one study. All right, so what can you guys do? As promised, that's sort of my first overview of how these things go together. Let's talk in practical terms about what you guys might be able to do with or without deeper psychological resources to help you out. So the first thing you can do is screen for PTSD. The VA has a wonderful validated PTSD screener. It's 4 questions. These are 4 questions you can ask any patient. If you get yes on 3 or 4 out of 4 of these items, then you want to really think about further diagnosing and treating PTSD. So these questions are, have you had nightmares about some experience in this past month? Have you had nightmares about a past experience that you've thought about when you didn't want to, right? So that's the re-experiencing piece. Have you tried hard not to think about it or went out of your way to avoid situations that remind you of it? That's that avoidance piece. And were you constantly on guard? Here's the arousal piece. Watchful or easily startled. And have you felt numb or detached from others or activities or your surroundings? Okay, the next thing you can do is measure it. So if you've got PTSD going on, there is a measure called the PTSD checklist. There is a DSM version 5 of this out on the VA website, or you can use the older version, which maps on to the DSM-4 symptoms. It's got over 15 items on it, but you can print it out and have patients fill it out and total it up, and it's really meant to be your blood test for this disorder, so to speak. It's kind of your best way to measure, are these symptoms getting better or worse over time? And we always want to try to track these things empirically to know whether or not things are getting better, rather than just trusting our own instinct or what the patient's telling us just in that moment of how they're doing. The other thing you can measure is pain interference as well. So, as I said earlier, we tend to see these things get better together. So if you can help pain interference improve, oftentimes PTSD can improve and vice versa. So there is the BPI, the Brief Pain Inventory, which is a lot more extensive, but I think practicality in primary care, you can simply ask a couple of questions. One is, how much is pain interfering in your life? You can ask that in terms of activities, or overall. Either way, having that on a regular, consistent basis, being asked to the patient, measuring it over time, can give you a good sense of interference. Okay, when you're treating PTSD, taking a stepped approach is really important here. So starting with engagement always first, and I'll talk a little bit more about engagement because people with PTSD are very hard to engage. They are anxious, right? So they're potentially avoidant. They're having issues with trust. There are lots of reasons why our patients don't want to tell us about the post-traumatic stress they're dealing with. Again, those self-blame, those intense self-shaming kinds of beliefs that they have going on will often keep people from telling a provider about any kind of trauma for decades, many years. And I've seen that commonly happen where patients are coming to us for the first time, revealing the trauma issue in the context of their chronic pain. So engagement comes first. If you do not have good engagement with a good provider alliance of some kind, you're not going to be able to do any of these other steps. So you start there. And then assessment. You can start with that PTSD screener that I just showed you with those 4 questions, and do a more thorough assessment if you feel like there's something positive there, or if you're lucky enough to have a behavioral health resource of some kind that can help you with that assessment. And then medications. Are there core things potentially you can treat there? Brief behavioral interventions come next in terms of stepping up, because I know these resources are hard to get to. So you might want to save those for folks that aren't getting better with these first initial pieces. Any kind of brief interventions that you might be able to accomplish as well. It's getting more and more common in primary care to do some of these, and I'll talk about those in a sec. And then obviously the ultimate, a referral for trauma-focused CBT, which is the gold standard treatment for PTSD at this point. So let me just say a little bit more about that. My prescribing colleagues have helped me put this together in the past to sort of give you the message, two big messages. One, if you're going to be using benzodiazepines with people with PTSD, as a psychologist here, my request to you is to please make these scheduled. Do not give this kind of medication to someone with PTSD in a PRN form. Because what they will do is use those medications at the peak of their anxiety, which behaviorally and psychologically can reinforce the anxiety and actually make it worse. So giving them some kind of scheduled basis to take this kind of medication is really important. And as you guys know, these medications stop working as well over time due to their physical addictive quality and the habituation. So there are definite pitfalls with this kind of medication with this group of folks. Now, it is incredibly relieving for these patients to have this kind of medication. So I understand there's a lot of push by the patients and even potentially within ourselves to want to give out this kind of medication to patients. So please know that scheduling is a really key component to using this medication. And then treating any of the core symptoms you can right away with medications if the patient's willing. So thinking about the core symptoms of depression, there's huge overlap with depression as well. We have good medications potentially to try there. So always thinking about things that you can do there will be wonderful. And then in terms of anxiety and nightmares, thinking about other kinds of medications that might help with anxiety or help, like prazosin with nightmares, can be tremendous. I've also seen that in the clinic here with our patients do quite well with that helping to some degree with their pain. So there's a double bonus. Okay. And then always remember, track your symptoms over time. If you're offering these kinds of treatments, you want to really empirically be tracking that. So again, this is your quote, blood test. You can use that PCL to look at PTSD specifically, or use a PHQ-9 or some kind of brief anxiety screener even, like the GAD-7. Some kind of metric that you give out regularly to the patient that you can total up to get a sense of if things are improving or not. All right. So when we describe what anxiety is to patients, this might be something that you might find helpful, both just in terms of your own understanding, but also in how you communicate to patients in terms of referring them to behavioral health for what we're going to be doing with them when we get them to work on their anxiety. And we talk about the 3 Bs when we're moving from a cognitive behavioral model of anxiety. And those 3 Bs include the body, the brain, and behavior. And those 3 things really interact and work together to increase anxiety. So this little triangle you're seeing out of these 3 circles is anxiety, is the triangle of anxiety here, and they feed each other really back and forth. So when someone's getting anxious, anxiety is a fear response. It's an emotional response to some stimulus that's not actually dangerous. And when they feel that fear response, your body is going to react. Your amygdala is going to be operating, and your heart rate's going to go up. You're going to shallow breathe. You're going to get sweaty. There's all kinds of physical symptoms that come with that. And when that happens for our patients, their brains are then starting to rope into all kinds of anxious thinking. Oh no, something bad's about to happen. I must be in a dangerous situation. Oh, not again. Here we go. Whatever it might be that is their catastrophizing or their self-blaming kinds of thoughts that come up. And as their brain is going, what they're wanting to do is get away from that, right? Who would not want to do that? And so they tend to try to seek safety. And the ways that they do that often is pushing away from the situations that are reminding them of that, pushing away from loved ones, trying to get out of the situation. So the way that we treat that is in these red boxes here, and I've drawn a line down this slide. And the way that I explain this to patients is that there's 2 ways to go about this. We can help you manage your anxiety so that you can live with it better. Okay, that's the medical model of I can't cure what you've got, but we can at least help you function with it. take like cerebral palsy and spasticity, right? Here's some things we can do to kind of help you manage that. Or on the other side, we can actually treat it and get to the root cause of this thing to help you not continue to get anxious over and over. Sometimes we use the management strategies to help people do the treatment. So on the management side, you've got relaxation. How do you bring the breathing down? How do you calm that body from that fear response with all that adrenaline pumping through? How do you use medications that might help bring down the symptoms but certainly don't cure them necessarily? And then what kinds of cognitive challenging skills can you use for those catastrophizing thoughts that you might have? All those things are management strategies. On the other side, what we do is attack the behavior piece and help people stay with the things that are making them anxious, because remember, the rule about anxiety is these are situations that aren't truly dangerous to them. So we have to be careful with exposure. We're not going to expose somebody who's in a domestic violence situation and say, yeah, you're scared of your partner, but stick around, stay with them, right? That would be dangerous. We don't want to do that. We also, for a woman who's been raped in an alleyway who can't seem to get down the street, go tell her to go stand in a dark alleyway that might be dangerous, right? But we do want to figure out ways to expose people to situations that aren't actually dangerous, that they are fearing. Is there a way folks can imagine being out and about on their own, where they're just doing that imaginal exposure, for example, and that would not be dangerous for them? So just to give you a sense of how this works in treatment, this is the rationale we give to patients. Something that you guys can do directly with PTSD is help with dissociation. So this is a really common phenomenon that happens with people with PTSD, is their brains have learned to seek that safety by essentially having an out-of-body experience. You see this really common with kids who have been sexually traumatized, where they dissociate really easily. What is happening, I guarantee you, with some of your patients with PTSD is that they are doing this with you in your exam room, and you may not be aware of it. And so what they're doing is stepping out of the conversation in their minds and not necessarily hearing everything you're doing. And why is this bad? Well, it means they can't hear what their doctor's telling them, right? It means they can't be present in their lives. But their minds have learned that's a safety-seeking thing. A lot of patients don't know this is happening. They've never heard of this before. You can ask them about this. Say, are there times in your life when you feel like you're just kind of removing yourself, where you're watching what's going on but you're not really there? And they'll say, yeah. And they'll tell you that it happens multiple times a day. If that's the case, you can teach them a very quick grounding skill. And tell them, what I want you to do is learn how to get yourself back in your physical space, because if you're not sitting there in your life, then you're missing out on what's happening right there. And that's not, again, a situation that's dangerous for you. It's not dangerous for them to be talking with their provider. That's actually important for them to be there. So the way you do this is you have them cue to the room, cue to their bodies. You can ask them, name 5 things you're seeing, name 5 things you're feeling, name 5 things you're hearing. Okay, using your 5 senses, what are several things to just bring you back in the room? So you as a provider can be aware if that dissociation is happening. It might be part of what's causing the disconnect in your ability to treat them. And also teaching them this skill concretely, okay? Behavioral activation is another thing I think many of you are starting to learn about if you don't know about it already. This is a treatment that was developed primarily to treat depression. It's been tested now for folks with PTSD in the VA. For folks that are less likely to be willing to do full-on exposure about their trauma, we've been using behavioral activation to help vets actually approach things that they're fearing. So if they've had an intense vehicle-related trauma and they can't go near moving vehicles, how can we get them to start to approach those vehicles by giving them BA targets around looking at pictures of cars? Starting to look at the car in their driveway, starting to progressively move towards things that right now they functionally aren't able to do. So using BA in this way in your practice, are there functionally things your patient is not able to do? Had a great patient in primary care I consulted on who was having difficulty getting his daughter to the bus stop. He was a vet. He was home on disability. He had intense back pain, and he wasn't able to get in the pool. He had fear of water. He had lots of these things that the primary care folks wanted to really target. But when they asked him what was meaningful, he said, I'd like to just get my daughter to the bus stop in the morning. So they did some small BA kind of exposure-based targets, and eventually when he was able to get his daughter to the bus stop, things really started to flow and improve. So think about BA as a strategy that you can use with patients. A couple of examples. I'm going to give you 2 examples of kind of classic patients that we tend to see who have PTSD and give you a couple of tips for how to deal with them. So this is an example of a 54-year-old mixed-race male who came in. He had a history of domestic violence as the victim of the violence. His female partner was abusing him pretty severely in the past, and then currently was with a woman with borderline personality disorder, also abusing him at this point, and a history of sexual abuse. So really uncomplicated, right? He had a PCL of a 69. So when we measured that initially, and anything above a 60 is in the very severe PTSD range. He had a history of post-surgical left sciatica, intense pain going on that was interfering with his work, and he was on nortriptyline. His behavior in clinic was that he was erratically kind of showing up for appointments. He was absolutely against medications. He didn't want to try anything new. And he was getting really explosively angry with the providers when he was feeling not listened to kind of out of the gate. He'd come in, and his main issue was kind of lower extremity issues related to the sciatica. But what he wanted to talk to doctors about was a numbness in his right hand and felt like he wasn't getting heard. So he's bringing in his style of acting, whereas a patient, he's coming from a place of someone who's got post-traumatic stress. He's going to be quick and easy to anger, maybe not communicate the most effectively. So an engagement tip here, right, for somebody like this, if you've got someone who's got this real erratic engagement, this kind of approach avoidance style with you, you want to take a little time. I know you guys don't have a ton of this, but you do have the ability to have repeat appointments. So burning some time in one of these appointments to actually just sit and listen and get less of the prescription writing or the tasking done, but more of the just listening to the patient can really go a long way. So really listening and reflecting and asking the patient if they're feeling heard. Are you really paying attention to the issue they have? Because I know we often walk in the room with large agendas with patients, especially in primary care, when you've got so many things to cover. So taking that step back and giving yourself permission to put those things aside can be really effective to just let you be there and listen to that patient right out of the gate. Then you've got the patient who's the I'm fine patient, but nothing ever gets better. So this was a 60-year-old Caucasian woman who had a history of childhood abuse, and her PCL was also in the severe range. She had a history of long-standing back pain with L5 to S1 discectomy surgery in the past, and she was on hydrocodone, bupropion, duloxetine. And over time, things just really weren't getting better. They just kind of were status quo. She had a really excellent engagement with our medical provider, long-standing relationship with him, lots of things tried, just not going anywhere. And the way she'd come in behaviorally, she'd either come in and say, "Oh, everything's great," the next month, "No, everything's horrible." And eventually, our medical provider said, you've got to do something about this trauma that you've got going on in your life. He screened for PTSD. Sure enough, she came out positive for that. What you guys can do in this kind of situation is think about what are the avoidance motivators for her. Why would she not want to talk about these things? If someone's got trauma, they can get really good at telling you everything is just fine. Don't look at the monkey in the tree. It's all good down here on the ground. We're all fine. They really want to avoid that. So a key tip-offs for you guys are look for that flat affect or that kind of very remarkably, weirdly a mundane reaction to something bad. This woman had bad things happen in her life, and she'd come in and she'd kind of go, "No, it's all right, everything's fine." It's that numbness that happens from PTSD too, where they don't sort of let in the kind of upset that most of us would feel with these kind of things. So that should be a clue to you. And then also you'll see this kind of pervasive potential sort of negative belief system, and it can be negative beliefs just in general about treatment, about work, about others in their life, and then particularly about themselves. And sometimes folks hide that from you. Sometimes they're hiding it from themselves because they're busy it's easier to be angry at other people. Okay, so those should be tip-offs for you to really screen for and look for PTSD as something to be treating here, because this was a diagnosis that was missed in this lady for many years, even though our provider had a great alliance with her for a long time. Okay, the best evidence-based treatments for PTSD remain cognitive behavioral treatments. There was a great Institute of Medicine report that came out that showed behavioral treatments outperform medications. That's not to say that medications aren't absolutely helpful potentially for many of these patients, but that these are the top therapies that have in fact been rolled out in our VA system as well. They're called prolonged exposure, which was created by Edna Foa, and then cognitive processing therapy by Patty Resick. They're both CBT-based treatments. They're both about 12 sessions apiece. They both have exposure as their main active component that help people approach that rather than continuing to learn to avoid it. And there are brief versions of these therapies that are being tried, but in terms of where we're at in the evidence base and building it, we're still testing these out, trying to figure out the best way to do it. There's been some toying around with online treatments. They're not really panning out. I wish that I could come to you guys and say, hey, here's the website, send your patients to it for treatment, but we just aren't there yet. Some cautions for you about trauma-focused CBT are, the iatrogenic dangers are if you get someone started in this kind of treatment and you start exposure and then they bail out of treatment, you've now just exacerbated all their symptoms. They've started the exposure, but they haven't made it through the treatment, and so it actually has made things worse. So we want to make sure that people are really ready to do this kind of treatment when they do it. You also want to avoid referrals to providers who might be dealing with repressed memory kinds of work where they claim, I can hypnotize you and put you back into your childhood and we'll figure out what really happened. That's actually pretty dangerous. There is some good literature that shows you can actually implant memories in people. Our memories are very fallible, very inaccurate, so it's not safe to do that kind of treatment with people who have trauma. Treatments that just explore the past but don't help behaviorally treat PTSD are also not a good thing. Requirements for doing good CBT therapy, you want to make sure that the person's actually able to attend their sessions, that they've got adequate support to deal with their symptoms getting a bit worse at the beginning of treatment before they get better. So are they stable enough to tolerate that? You obviously need a trained provider, and then a good enough mental status. And I'm not real stringent about this. I've treated people on very high doses of opiates. I've treated people who are still smoking marijuana. I've treated people with traumatic brain injury. I mean, there's lots of things that can compromise mental status but still allow this treatment to be effective. It may take a little longer for some folks who have mental status issues, or if they're comorbid kind of maladaptive uses of drugs or substances, or things that are affecting memory. So benzodiazepines, I'll go back to again, can really be contraindicated here because they affect short-term memory incorporation. So again, if you're tracking somebody down this gold standard of treatment, we want to try to minimize any impact on mental status we can. There's an app for that. So there are a few apps now growing. The VA really is pioneering a lot of these. These are the three that I feel comfortable recommending at this point. There's not a huge evidence base behind them, but they're really functionally pretty useful, I think. The main one that you all might be interested in is PTSD Coach, because you can give that directly out to your patients, and it's a great symptom management app that they can use. It's got the PCL built right into it, so they can symptom track right on there and share that with you if they feel like. But it's got some practical exercises to go through for how to calm themselves, how to reach out to others, how to do various things to kind of control the symptoms. And then there's a couple of apps they're creating now to help us who do treatment actually do that treatment a little bit easier with patients, and that's what CPT Coach and PE Coach are. And then last, there are some resources here that I'll leave you with. The VA hands down does the best job at putting these things together. And then if you guys ever have questions or feel like I'd be helpful, there's my email address.